Thank you so much for joining us for today's presentation, Improving Patient Care and Throughput in the ED, Leadership and Execution. My name is David Diadana, and I am the Senior Editor and Content Strategist responsible for the Health Administration Program at Springer Publishing, an independent publisher known for innovative textbooks, professional references, and clinical products in the fields of nursing, behavioral health sciences, and medicine. Before I introduce the presenters, please note that this webinar will be recorded, disseminated, and posted on our website in case you miss any part of today's presentation. If you have any questions, please type them in the Q&A box on your Zoom control panel, and we can address those at the end during the Q&A session. And if you forget to ask a question, there will be a brief survey sent at the end of the webinar, and you can include your question there. We greatly appreciate all your questions and feedback. I'm delighted to introduce today's presenters. Dr. Corinne Karupin is Professor Emerita of Operations Management at Missouri State University, where she continues to teach quality measurement and management for the MHA program. Dr. Robert Cavanaugh is a general surgeon and physician executive with 15 years of progressive leadership experience with numerous integrated health systems. Most recently, he served as president of the North Region for Freuder Data Care Health, responsible for the overall strategic direction and operational execution of all elements of the 9-hospital health system in northeastern Wisconsin. All right, so we'll let others trickle in, but with that, I'm delighted to hand it over to Dr. Krupin and Dr. Cavanaugh. Please take it away.
All right, well, we are thrilled to join you all today to talk about this case study. This is an actual case of an emergency department that was really swamped by volume in a large community hospital setting. The names have been changed to protect the innocent, but we will walk through this case. This is an actual case that I've been involved with. This is the type of teaching instrument that Corinne uses in her class, which is using a project approach. And so just want to make everyone aware, and then we'll talk more about it and explain the details of the case. Let's go to the next slide, please, Corinne. So the current status that we were faced with is an emergency department that had extremely long wait times, patients waiting in the waiting room for several hours. In addition to that, the patients had a long length of stay after they got back into their bed in the emergency department. Patients got frustrated waiting so long, and so actually they would check in, and then a percentage of the patients would actually leave before being seen or before their treatment was complete. And those long delays led to some poor patient outcomes, patients deteriorating in the waiting room. Unfortunately, there was actually a patient demise in the waiting room, so very, very poor outcomes. And of course, those long waits, as we all know, are extremely frustrating and extremely low patient satisfaction scores from the emergency department. Next slide. So just some pictures, not from the actual emergency room, but to give you an idea. And I'm sure many of you have been in a crowded patient care environment, but this is just to give you a sense of what it was like both in the waiting room and in the extremely busy emergency department, with patients actually being in the hallway. We had a term for that, hall beds instead of actual patient rooms. Next slide. So these are some metrics from the very peak times that patients were being seen. Again, remember, this is the busiest emergency department in the state. So the highest point that we hit, 310 patients treated in a 24-hour period, believe it or not. During those peak times, the waiting room could get up to 110 patients waiting who had already been checked in. And then boarding was a big issue. So what we mean by boarding, these are patients who have been seen in the emergency department, triaged, treated, and determined they required admission to the hospital, but the hospital did not have any open beds. And so they had to sit or be boarded in the emergency department on an inpatient status until a bed became available. There were actually patients who completed their entire hospital stay in the emergency department, seen, admitted, and discharged from the ED. And so that was a huge issue. Length of stay, which is the amount of time the patients were actually in the emergency department, was 280 minutes plus. So you're talking, close to 5 hours of being in the emergency department. There were patient safety events in the waiting room. Patients who had deteriorated, came in bleeding, and lost a significant amount of blood, for example, or worsening chest pain. So not great outcomes in the waiting room. Left without being seen. We talked about that rate sometimes exceeding 10%. So 10% of the patients left before they were able to be seen. And then extremely low patient experience scores. We would send out surveys and get some pretty robust feedback from patients and families who had to wait a long time. Next slide. This is an example of the dashboard for tracking some of these metrics and keeping track by month what the length of stay was, as well as some of the other things like patient safety metrics and the left without being seen rate. Just to give an example of where the target was, the year-to-date actual, and then the monthly tracking of each of those metrics. Next slide. So clearly there was a need for some robust change, and I'm going to turn it over to Corinne, who's going to talk about some of the methods that we used. Corinne.
Yes. Thank you for joining. So the path taken to turn things around was Lean Six Sigma. And before we explain how Lean Six Sigma was used in this project, I would like to review very briefly some of the terminology. So when I ask in my class, what is lean? The typical answer is a reduction or elimination of waste. And actually, that's only a means to an end, the end being creating a smoother flow through the system. Now, what is waste? Well, from a lean perspective, waste is anything that does not contribute value to the customer. In a hospital or in healthcare in general, the customer is often the patient. So there are typically 8 types of waste. I'm going to mention them very briefly. Overproduction, doing more than necessary. So for example, it's photocopying some documents that have already been stored in a digital format. Inventory. Well, inventory are things that lie there, they're idle, they have already been paid for, and they're not generating revenue yet. They also occupy waste. And when we talk about drugs, they can become obsolete, which is an obvious waste. Defects, when they occur, they have to be corrected. That consumes time and resources, which is a waste. And of course, they can lead to litigation. Motion, that's unnecessary movements, trying to find things that are not in the right place at the right time. Extra processing. Well, here's an example, I think, with which everybody is familiar. You go to the doctor's office, they give you 3 sets of forms to fill out, and you find out that on each set of forms, they're asking sometimes the same questions. So that's a waste of time that does not enhance, the experience for the patient. Waiting is a waste of time. Transport, if the patient is moved from one building to the other, from one floor to the other, from one room to the other, that does not enhance the health outcomes. It does not contribute anything to the patient's experience. And finally, underutilization, that's when people do not perform at the top of their license, which is a waste of their skills. Now, Six Sigma is a lot more quantitative. And the goal is to reduce or even eliminate defects through a reduction in variation. So what is variation? Variation is uncertainty. When the weatherman says the weather is going to be variable, we don't know what's going to happen. Should we take an umbrella or not? When the S&P fluctuates widely, investors panic because they don't know what's going to happen next. So this is the same situation. Now, fortunately, our patients, our customers are reasonable human beings. They expect some variation, but they're only willing to tolerate so much. And how much they're willing to tolerate on this graph is represented by those 2 vertical green lines. Now, the process has some variation, that's inevitable. And you can see here the process distribution here, the output. So it's represented by that bell curve. And the width is the amount of variation. So you can see here this process is not properly centered, number one, but also it is so wide, has so much variation that spills over what the customer is willing to tolerate. And all of this is unacceptable. It's defect. A useful and very popular analogy is the car and the garage door. So the garage door is what the customer is willing to tolerate, and the process is the car. Well, in this first instance, you can see it's a big fat car. It's never going to fit into the garage door. Now, even if the car has exactly the same dimensions or just slightly less than the garage door, it's not going to work. The car would have to be perfectly centered, and as you go in, you could not deviate 1 millimeter to the left or to the right. And as one of my students pointed out, even if you were able to do that as a driver, you would not be able to open the car door, right? So what we want is a car that is small enough or a process that is narrow enough to fit within the garage door, even if it's not properly centered. In fact, when we talk about Six Sigma quality, what we really mean is one car going through a two-car garage, sorry. Okay, so for those of you who have students or employees, associates who are not familiar with statistics, it can be a problem. And for example, in my department, I teach the quality course in DMAIC, as David mentioned, but they eliminated the prerequisite, the statistics prerequisite. So I have students who have never had statistics, and I have some who have not seen a stats book for 20 years. Okay, so it's very difficult to cover all of statistics, obviously, in one course, but so what I do is I refer them to LinkedIn Learning. There are many other platforms available, and I make sure that they watch and go through a list of modules. Then I give them a quiz. It doesn't count, but it's just to see how much they know. And then when I cover data visualization, I introduce some of the basic topics that will be in the book. That will be in the course. So there are ways to make sure that they have at least a minimal knowledge of what will be needed for Six Sigma and statistical process control. Now, there are lean tools and concepts. There are Six Sigma tools and concepts. They can be integrated, combined into this DMAIC framework. So define, measure, analyze, improve, and control, which are essentially the phases of a process improvement project. And now I will let Rob talk about the project.
Great. Thanks, Corinne, for that background. So, following the DMAIC framework, we'll start with define. So we have to define the process. The text in this slide is kind of small, but you can see step by step, we're defining how patients show up into the emergency department, either walking in or coming by ambulance, and then going through these various stages to either being admitted, transferred, or discharged to home. So we use this analysis to start with a fundamental understanding of what's happening through the process. Without understanding the process, it's impossible to identify the bottlenecks and what really needs to be impacted. When you do this and you're going through this activity with your staff and with other folks, obviously you're talking about improving the process. People can start to get some anxiety, right? They can start to think, well, I understand what's happening in the current process and the future is unknown. And so, of course, that can create some fear and anxiety with the staff. That's where leadership comes in, where the staff and other folks, they need to be reassured that this is all in the interest of improving, the quadruple aim, which is really focused on the patient experience, the cost of care, the quality of care, and as well as the experience for the caregiver. And so that reassurance that, hey, this is going to be better for patients and it's going to be better for our team, our physicians, nurses, therapists, techs, everyone else. And it's really important to focus on what we call the WIFM, the what's in it for me, the benefit for the staff, that they'll be more satisfied with the care that they're able to deliver. Corinne, do you want to talk about the challenges?
Yes, so as you mentioned earlier, a major deliverable in my class is a process improvement project in a healthcare organization. And so most of my students are in healthcare. Some of them are not. So those that are not, I pair them with someone who works in a healthcare organization, and they have to find in their job or their unit a dysfunctional process. And the first question that they usually ask me is where to start and where to finish, because sometimes the projects may, the dysfunctional process may spill over multiple departments. So there's only one semester, there's only so much time available, so I make sure, that they have something that is manageable. So I say usually between 15 or 12 and no more than 30 steps in the process. So here comes the next challenge. Then they will say, well, what about how detailed should the steps be? Well, there should be a certain level of aggregation, because I've seen projects, at least the proposal, and they come up with really micro motions almost. The staff took a form, the staff entered the name, pressed next, the staff entered the address, pressed next. Okay, so that's too detailed, and that's not going to generate a lot of opportunities for improvement. Then also make sure that before they start, they need to be reminded that they will have to collect data. They will have to observe and collect data. That means that they need supervisors' approvals. And some of my students in the past have waited and waited to get that, and then at the end they realize they cannot get the approval. And then finally, that's something I forget to tell them, is only when it's too late, they will struggle and use Word or some other word processor to come up with this flow chart. And they can use Visio, or there are many other templates out there that are easy to use, and they can just drag the shapes. So remind them that they don't have to make it too hard on themselves. Rob, your turn.
Yeah, thank you. So going back to the project of improving throughput and experience in the ED. So one of the important steps to start with is a project charter. Again, that helps everyone who's on the project team to understand what are the goals, what are the metrics, what's the business case, what's the scope. The scope creep can get out of control, and now you're trying to solve world hunger and cure cancer. Who are the team members who are accountable? What are the outcomes we're driving towards? And then how much time do we have, and what's the budget? This is a very succinct document that just helps everyone align and get on the same page with what is actually trying to be accomplished. All right, next slide.
Okay, so it's a dysfunctional process. So we need to find out where the waste is and how much waste there is. So a useful tool for that is the value stream map. And in the project that Rob is describing, they put it on butcher paper. And so the value stream map basically is the flow, the workflow. So just like the flow chart, but it's from a lean perspective. That means that it's going to try to identify where the waste is and where it isn't. So what contributes to value, what does not contribute to value. And you can see here the process steps are the post-it notes, and people take measurements. So how long does it take to perform a process steps? How many people are waiting and for how long? How long does it take to prepare the room for the next patient, etc. Now, you can see here the little triangles that represents inventory or wait or delays. You can also see the little Kaizen bursts. So Kaizen means improvement. Those are the starbursts that show where improvement is needed. Now, as you go through this exercise, in the real world, you're going to have a lot of blame game because people believe they're doing the best they can, and they probably are, and the numbers don't look good. So the leadership here should explain, well, that the data don't lie. If people are not involved in the data collection, they may not believe the data. So make sure that they're involved in some way. And also, they may not be responsible because there's a lot of interdependence in a process. For example, if you have, let's say right here, this particular step, a bottleneck, well, it's going to affect the work upstream. They won't be able to send more flow units, whether they're patients, orders, or whatever, through the system. So they will be blocked. And then downstream, there will be delays because they're waiting for work to come in, flow units to come in. So there is a level of interdependence that needs to be explained. Now, in class, this is usually the eye opener for my students because they identify how much time is wasted. So how much time does not contribute to value, is non-value added and they compare that with the total time taken by the process. That's what we call efficiency. And it's typical for the efficiency number to be around 10%. So only 10% of the time spent in the process contributes value from the perspective of, let's say, the patient. So that's an eye-opener in the classroom. Another useful tool to show waste is the spaghetti diagram. So the spaghetti diagram essentially shows traffic and its intensity through the layout of a facility. Here we used a simplified layout of the ED that was in the project that we're describing. And you can see, so long line, long thick lines. So what does that mean? Long distances are being traveled very often. That's waste. There are also some other forms of waste that can be visualized. You can see that the ambulance bay entrance is pretty far away from the trauma rooms, which are right here. So that means unnecessary distances that have to be traveled, but also a lack of safety for the patients that are being transported. Also, you see that there is only one documentation right here, provider documentation area. So all the providers can only go to one area, which is located far away from some of the exam rooms. Again, another form of waste. So we have waste. We don't want to use the Band-Aid approach. We try to come up with the root cause of the problem. So to engage in this root cause analysis, a team is going to brainstorm and come up with all the possible causes and organize them in a cause and effect diagram. So the cause and effect diagram is also called the fishbone diagram. You can see why. The head of the fish right there is the problem, so the long length of stay. And the types of causes are measurement, methods, materials, people, equipment, and environment. So those are typical types of causes. There can be fewer, there can be more. And so then the team brainstorm. A useful tool to help in this brainstorming exercise is the 5 whys approach. So let me give you an example. One of the problems related to people was unfriendly staff. Then you ask yourself, well, why was the staff unfriendly? Because it was too busy. Why was it too busy? Because the process was inefficient. Why was the process inefficient? Because there was a poor layout and no standards. And at the end of this exercise, I'm showing now, you won't find it right away, but it was determined, you can see here in red, unstandardized discharge procedures, not only in DED, but also at the hospital level, and Rob will elaborate on that later. And also something that kept on coming back was the poor layout. Now, we did not come up with those two right away. there was some further analysis in a Pareto diagram. So what is the Pareto diagram? It's a tool that helps us organize, prioritize the causes that need immediate attention. As you saw in the fishbone diagram, we had tons of causes. So what you see here in the Pareto diagram is the frequency with which each cause contributes to the problem. And then we use a bar chart to display those frequencies in descending order. Now, why Pareto diagram? Well, it comes from Vilfredo Pareto, the Italian economist, who in the 19th century said that 20% of the people owned 80% of the wealth. So we were not talking about the 1% yet, but the idea was that there were just a few people that that own most of the wealth. Well, here's the same thing. There are just a few causes that result in the majority of the problem. So we develop a cumulative curve, cumulative percentage curve. We look for 80%, and then we see where it meets the curve right here. So what does that tell us? That tells us that the no standard procedures for discharge, as well as the poor ED layout, were the causes that we needed to concentrate on right away. So they were the priorities. Now, the students, sometimes they look forever for a tool that's going to give them the Pareto diagram that they want. Just remind them, if they have access to Excel or some other spreadsheets, very easy to do. All you need is the list of causes and their frequencies, and then you click on histogram, and then there's an option for Pareto diagram. Okay, now the exciting part, and that's Rob's turn.
So back to the DMAIC framework, right? We've moved through several of the steps, and now we're on improve. So how are we going to get rid of the waste? Well, there were really two areas that needed to have a focus. So the ED, of course, there was opportunity to redesign the workflow and eliminate some of the waste, helping people be more efficient. For example, adding printers. So that everyone didn't have to go to the place where there was one single printer to print out patient discharge instructions. Moving an ED provider out to the triage area to get the workup started really started to speed up the ED length of stay, and then redesigning the schedule so that you had, at peak patient volumes, you had the most providers there during the day. It really helped to balance out that supply and demand. Now, it's not like you go to a group of physicians and say, hey, here's a great idea. Let's change everything that you're doing. And everyone says, great, let's do it. There's always resistance to change because I know what it's like today, and I don't know what that future state's going to be like. This is where leadership is really important, where you have to get the physicians, the nurses, the therapists, the techs, the phlebotomists together. First of all, include them in this work, not just come and hand them the final product, but include them all along the way with this project. And then come back and remind people, hey, we're here to take care of patients. This is really going to improve patient care, and it's also going to improve the situation for you. For example, the ED physicians were compensated based on a productivity model, which means the more patients they see, the more money they make, and improving efficiency is going to improve their compensation. So that's the WIFM. That's the what's in it for me on the ED side. A big part of this bottleneck in the emergency department, after all of this analysis and using some of the tools that Corinne shared, turned out that the reason patients were boarding in the emergency department was because the inpatients were not being discharged in a timely fashion. And so the hospitalists were in this antiquated model where they would show up and see their sickest patients first in the morning, and they would see the patients who were slated to be discharged last. So they might have 16 patients to see, and it's not until 4 or 5 o'clock that they're seeing the patients to be discharged, which means the patients didn't go home until late in the evening. That workflow had to be completely redesigned so that the hospitalists would see the discharging patients first And there was a lot more to it. They would be communicating the day prior and writing prescriptions and letting family know, hey, your loved one is going home tomorrow, so that everyone could prepare. Again, there's not a whole group of people, cheering when you bring new ideas. There's always going to be resistance to changing that workflow. And so helping people understand, the benefits to the system. The hospitalists didn't like having to see their patients in the emergency department sit down there for 24 or 48 hours. They much rather would care for the patients on the inpatient ward. And so helping them understand this was going to improve that for them really helped to demonstrate the benefit to them. So 2 areas of focus, both in the ED and on the inpatient units, to redesign the workflow, optimize patient flow, communication, and improve throughput. All right, next slide. So this is just an example of after. If you remember that before dashboard, there was a whole lot of red. I don't think there was any green, or maybe there was one green square. There's more green here, but it's not all green. This just shows progress where there was improved length of stay, reduction in patient safety events, the left without being seen coming down significantly, and patient satisfaction starting to creep back up out of the cellar where it was before. Because again, patients want good care, they want timely care, they want good communication, and all those things improved as throughput improved. Next slide.
Another way to show improvement is with the statistical process control chart. And you may recall from the beginning that the length of stay was around 280 minutes. But the process width, that variation we talked about earlier, was between 240 minutes and 320. So that's a gap of 80 minutes, okay? Now, after the improvement, you can see that the average actually met the target of 159 minutes, so a major drop. But there was also a decrease in variation, so going back to Six Sigma earlier. So now it's between the process width, or the variation is between 130 minutes and 190. That's 60 minutes. So we go from 80 minutes to 60 minutes in terms of variation. So that's a 25% reduction in variation. What does that mean? Well, it means that now that we have a more predictable process, because it's narrower, its distribution is narrower, there is less risk that the length of stay will be so long that it will spill out of what the customer or patient considers to be acceptable. Okay, so let's go back to teaching a little bit. There is no time in one semester, and most of the students don't have also the authority to implement an improvement. So what can you do? In my class, I don't use the value stream map. I use a tool that's pretty much similar. It's called the process activity chart. But if you use the value stream map, that's just the same. I have them identify, after they have done the analysis, identify all the areas of improvement, and then develop the future state VSM. So after those improvements, what do they envision the process will look like? So it's the future VSM, or the future process activity chart. I have them recompute the efficiency, and there better be a major improvement in efficiency. So remember, efficiency, value added time divided by the total time in the process. Now, all this information in a process improvement project is documented in the A3 report. I also ask my students to come up with the A3 report. So what does the A3 report do? So it's a one-page document that tracks the project and its progress throughout the phases, throughout the DMAIC phases. And you can see I'm not going to re-explain what we did. There are multiple formats. Sometimes it's all text, sometimes it's all graphs. Remember, it's a communication tool because it tracks the progress. So it's a communication tool within the team and sometimes the stakeholders. So in the end, as Rob showed you on the dashboard, there was still some red. So here there's a follow-up section that shows, okay, what else needs to be done? Reinforce accountability, reevaluate the compensation system, because we changed the way that people are being evaluated. So there are still some changes that needed to be made, some tweaking. And like I said, there can be multiple formats, but it's a communication tool and it cannot be too wordy. And the students who opt to only use text, typically they end up with an executive summary. So I know an executive summary is going to basically give you a summary of the project, but it is not a communication tool that is used within the team. And so they end up with this long text and that nobody is going to read. Okay, so just wanted to share that information. Now let's make sure that we keep those improvements in place. Rob?
Yeah, so control, right? Again, we're getting towards the end of the DMAIC framework here. How do you maintain? How do you keep the improvements sustained? And so, sharing metrics, sharing data, put things up that have like a visual management board where you update the reports with some frequency people can see, and it brings top of mind, hey, this is what we're focused on, let's make sure that we don't backslide. Sharing this information at huddles, giving physicians their individual reports that show their own performance. All of those things are going to help maintain the focus on those key metrics and keep the performance in the area that it needs to. So again, the most important thing is transparency with the data. Sometimes there's some difficult conversations that are required when you have people who don't get on board. There's going to be a small percentage of people, no matter what you're doing or how great the idea is, that either aren't going to believe in it or are going to be stuck in their old ways. And so sometimes there's some corrective action that's required. And then making sure that everyone understands, the responsibility they have to participate as a team. So again, it's easy to backslide into old ways, especially before the changes have become hardwired. And so accountability, reminders, keeping things top of mind and making sure that the new way of doing things gets hardwired is critical. Let's go to the next slide. So maybe the most important slide in the deck is the importance of leadership throughout this entire process, right? Change is hard. That's why it's so hard for all of us to lose weight, because losing weight requires behavior change, and behavior change is hard. And so getting physicians and nurses and other folks to change the way that they're used to doing something and changing workflows are difficult. There has to be an elevated level of accountability. One of the techniques that we used was unblinded data. Physicians are naturally competitive individuals, and so you put a graph up there, and some people are performing really well, and some people are at the bottom of the heap, and their face turns red, and they want to know why they're not performing well. And so having that unblinded data can really help with change management. You're not trying to shame anyone. You're just trying to create transparency around who's following the process. And then I've mentioned this a few times before, but that's helping people understand, how does it benefit them? What's the WIFM? What's in it for me? So in this project that we used, right, the hospitalists didn't like their patients being stuck in the emergency department for hours and hours. They wanted them to be up on the inpatient wards, to be cared by the nurses that they're familiar with, and to be in an area that it's convenient for them to see. And so again, having the hospitalists understand that this improvement would help get those patients admitted faster, that was the benefit to them. We talked about the ED physician compensation plan, and then the quadruple aim, right? We're all in healthcare because we want to take great care of patients and improve their experience and improve the care and lower the cost. And so explaining to everyone how this will advance the quadruple aim is certainly beneficial. So the importance of leadership cannot be underscored enough. And I think that concludes our presentation. We'd like to move into the Q&A section, and we'd love to hear from any and all of you, questions that you have, or any areas that you want us to go deeper.
Well, thanks, Rob and Corinne. Great presentation on the case. And, yes, please feel free to add questions to the chat or the Q&A so that we can ask Rob and Corinne while they're available here. One question that came through to me, what are the benefits of Lean Six Sigma certification? This might be for Rob. Why should professionals consider it given their professional practice?
Yeah, happy to. And Corinne, please jump in. So, on the delivery side, having someone who is Lean Six Sigma certified adds a lot of structure and knowledge to when you're pulling people together to start one of these projects. Otherwise, it can be a little haphazard. It's hard to know where to start. But you've got someone with the expertise, they can help keep the team organized and on track and pull people back when you start to run into issues like scope creep and people are wanting to fix things that are outside the area of the problem. So having someone who's a green belt or a black belt or has some expertise in Lean Six Sigma can be extremely valuable to a project like this, just to keep everything organized and moving forward.
Great, thanks. Corinne, as a follow-up, do you encourage students, or does it depend on the student to go after that sort of thing when they're done with their MHA or other degree program?
Okay, so throughout the course, I encourage them, and some may be interested, others will not be interested. And so those who are interested, then I try to guide them, provide them with extra materials. We try to provide a solid foundation for certification. It is not, for example, the book that we will talk about later on is not a certification guide, but we provide a solid foundation, and then I refer the students to some extra materials to complement their knowledge. Yes.
Great. All right. Another question. So the DMAIC framework was a key part of this presentation. It seems like a great organizing method for teaching students, but in comparison to the PDCA or others out there, why choose the DMAIC and what's your experience with teaching from that versus others?
So we cover the PDCA at the beginning of class, and actually once we get to the DMAIC, we see the analogy. So DMAIC is very much rooted in the PDCA cycle. I like to use DMAIC because it's more structured. It's also, it's more structured. It's got tools attached to each part. You can use the PDCA as a framework in your class, of course. I prefer the DMAIC because they go through a project and I think it's more structured and more detailed. So, but it's just a matter of preference. I don't think we can say one is better than the other. For me, it suits, I think, my teaching style better, and I think my students prefer it as well.
If I can add, Corinne, so in this project, for example, right, we follow the DMAIC framework, but at the end, we hadn't achieved all of the goals that we wanted to. And so that's where the PDCA comes in, where it's, okay,
Yeah.
well, we've made progress, but we're not far enough. Now let's try something else and doing some short-term, some short interval changes. And then, okay, now it's a little bit better, a little bit better, a little bit better, continuing to tweak. And it's important to understand what's the impact of the tweaks that we're making and what else do we need to target in order to crank things up and achieve the goals that we're driving towards.
Well, yes, you're right. That continuous improvement, Deming's wheel, it's never over. We can
Right.
always do better.
Right.
Right. Well, thank you. We have a question in the chat. Why are ED physicians paid for productivity and not also paid for performance, and which is broader and includes quality of care? Rob, do you want to answer that?
Yeah, sure. So, to keep things simple, our physicians did have a quality bonus. It was a smaller component of their compensation, but a bulk of the money they take home is volume based. And so the more patients that they see, the more they get paid. But there was a quality bonus that included, some things in there. It was just a much smaller element of it. I would say today, most physicians who are working with a health system or part of an accountable care organization do have some elements of quality in their compensation. But across the board, if I looked at the entire United States, how most physicians are compensated, most of them are still on a productivity model, which means they're paid, more for every patient they see or procedure they do.
Thank you, Rob. Any other questions? Please feel free to type them in, or you can ask questions in the survey afterwards, and we can get back to you after the presentation's over. Corinne, do you want to go to the next slide? All right, so we do have their book out. It's available, and you can get a 25% discount by using the QR code here. This is a great book that just came out about quality in healthcare. And Corinne, Rob, do you want to say anything more about it?
All right, so let me start, Rob. So first of all, Rob was the ideal co-author because of his wealth of experience in the field. So I think the book mixes our, essentially our backgrounds. So we try to provide what is real. So earlier we said that, he described the project in which he was involved. I described the live project in my classes, and we followed the same format in this book. We wanted to have something that was real, that students could follow through, and that's why we have an interactive running case that describes a full project. And so that's essentially the book. Of course, we cover the various concepts, but there is a running case that is embedded into the book. We also try to keep it real in other ways. So we talked about people that are actually using those tools, and Rob interviewed a lot of the people in his organization, and they demonstrate how they use the various tools that are covered in the book in their daily work. And then we talked about statistics earlier and how sometimes it's complicated for students. Well, we have also video tutorials that explain how to develop each tool, how to use each tool, and we show demonstrations. And Rob, would you like to add to this?
Yeah, just to build on what you said, Corinne and I were great partners in this because she's got the expertise in teaching and quality and process improvement, and then I've got the actual experience in healthcare organizations, and so together we really collaborated well on this. I just want to build on what you talked about the interviews. So I had the opportunity to interview individuals in different roles. So a director of quality, someone in pharmacy, Lean Six Sigma certification, people doing process improvement, and give them the opportunity to talk about what they're working on, the skills, the tools and the skills that they use in their job. So every chapter has one or two individuals who explain, hey, this isn't just theoretical. These are the tools that I actually use in my daily work. We also included ethical scenarios and questions at the end of every chapter, just to get you thinking about some of those real world things that you're going to encounter in healthcare. It's not all clear cut, black and white. There are some challenging things in healthcare for sure. So just to get you thinking a little bit different. And then we completed the book talking about accreditation, because that's a big deal in healthcare, making sure that you stay accredited. And so talking more about that. So those are just some of the additional elements in addition to what we've already talked about today in the webinar, just some neat features of the book that I think you'll find valuable.
And as far as certification is involved, we also include some extra materials for students seeking certification. Those materials are not in the book. They're available online in the student resources, but they can be useful chapters to look at, along with many, many problems to practice. Because yes, students may not have the knowledge, especially the statistics knowledge, in the course right away, but practice really helps. And so we try to provide a lot of examples as well as a lot of practice problems.
Well, thanks both. I also want to mention that the tab on the cover, the Course Connect tab, we have an interactive platform where the tutorials, the interviews, and other interactive features with the textbook are available to students, and it's a nice platform for them to engage in this practical text that will help set them up for hopefully future practice success, whatever they get into, and deal with when it comes to quality management. So we're glad to share you with that the book here. Thank you so much for coming, Corinne. If you want to end on the last slide, and we appreciate your time today. If you have any other questions, please send them to the marketing email featured here, or reply in the survey with any other questions. And we look forward to seeing you at future webinars for Springer Publishing. And I just want to thank Rob and Corinne again today for their excellent presentation of that case, and very helpful for everyone learning in quality in healthcare throughout in the sector. So thank you so much.
Thank you.
Thanks for joining.